Thanks, Susan. So it gives me pleasure to introduce Stephen Grover, who many of you know. He's a professor of medicine here at McGill. He's the director of the CHIP program, which, if you don't know what that acronym is, it's Comprehensive Health Improvement Program. He's been the director for a while. And I'll read this paragraph because it's very well stated from his bio, and I don't think I could paraphrase it. Stephen is an avid but slow jogger and walks everywhere in any weather. He has been happily married for over 40 years to his wife, Mara, who is also a physician, a respiratory physician, I'll add. They have 4 sons who never listen to them and 2 dogs who occasionally do. He also has 2 wonderful daughter-in-laws, both health professionals, who he hopes will look after him in his old age. So I'll pass it over to you, Stephen.
Well, thank you, Ben. It's a pleasure to talk about this topic today with all of you. I got to tell you, I'm not an expert in the care of the elderly. While CHIP for the last 25 years certainly saw its share of individuals over the age of 65, and we even had 80 and 90-year-olds there, it was not a preoccupation for us. What were we doing for the elderly? We were just trying to help people who had a particular disease issue. And we've subsequently learned that while it was really beneficial to a lot of our patients, particularly the older ones, it wasn't top of mind. Let me declare a conflict of interest. I'm 68 now, and I'm getting older daily. And I've got to tell you, I was always very reluctant to consider myself a candidate for long-term care. But after doing the reading and the research for this presentation, I have no intention of ever going into a long-term care facility. The learning objectives should be, will hopefully be today, why we should avoid aging at all costs, how we can avoid long-term care as long as possible, and why medical assistance in dying may become a reasonable alternative to future long-term care services. Now, I'll talk just briefly about medical assistance in dying. One of the things that got me interested in this topic is about 4 months ago, I was on service at the MGH, and I had a patient come in after multiple falls. This was her, second or third admission for falling at home. And finally, the family said to her, we just can't manage with you any longer, and we're going to have to get you into a placement. At which point she said, I'm not going to any of these places. I want to speak to the medical assistance in dying consult service. I'd rather go that direction. Now, to the best of my knowledge, she didn't qualify for medical assistance in dying. She didn't have an untreatable medical problem. She wasn't suffering. She wasn't in pain. She just kept falling. I spoke to the medical assistance in dying consult service yesterday just to find out what happened. And they assured me, no, they don't put people out of their misery just because they don't want to go to a nursing home. But after you see the data I'm going to show you, you may agree with me that over the next 10 to 20 years, this may become a reasonable alternative. So let me start with a little quiz. Place your bets. If you had to guess how many inspectors and how many inspections annually are done by the inspectors for long-term nursing homes in Quebec, or the inspectors for animal rights, agriculture, and the food chain, or inspectors for the Quebec Office de Langue Française, think about the number of inspections and the number of inspectors that exist in these different agencies. And I'll come back to this towards the end of the presentation. Talking about the COVID pandemic, we actually did very well in Canada in many, many metrics. For instance, if you take a look at the share of people who received at least 1 dose of COVID-19 vaccine, Canada was right up at the top with the best of the countries. We were lots better than the United States, of course, United Kingdom, France, most of Western Europe, and Canadians, as you can imagine, moved quickly to get their vaccinations once it became available, and they were told this is what you're to do. So we did very well on the vaccination side. And when in fact you look across the various provinces, you can see that we're looking at least one vaccination for 80% plus of all the regions of Canada. So we did great on that. As far as COVID deaths are concerned, I'm not going to talk much about COVID cases today because the trouble with cases is everybody's been testing and not testing. So the only hard outcome I think we have are COVID deaths. But if you look at COVID deaths, you see we also did very well, way below United States, United Kingdom, France. And we're up here at April 15th, 2022. So these numbers are current. We've stayed ahead of the curve on this one just beautifully. However, when you start to dig deeper, one of the things that's interesting about this is you can start to see, well, how did we do across the country in various regions and various provinces? Because it gives you an opportunity, as many of you know, in a lot of epidemiologic research, to look at best practices, look at regional variation, look at places that were particularly successful, places that ran into problems. There was a lot going on over those 2 years. And you can see here, if we look at total deaths or deaths per 100,000, it ranged anywhere from 23 in Prince Edward Island to 189 in Quebec. And most of the provinces, you know, were up in the 50 to 150 range, let's say. And this gives you a sense of what the pandemic, what the outbreaks looked like for most of these places. The critical issue when you look at Canada is there were really 3 big waves, mortality waves, if you will. The first big wave that we all remember very well at the beginning of February 2020. By Christmas of that year, we were into another big wave. More recently, as Omicron set in, people think Omicron was actually a fairly benign virus in terms of mortality. In terms of complications. But the fact of the matter is our mortality data was actually very significant in the third pandemic. There were smaller ones in the middle, but they didn't have as big an impact in mortality in Canada. And if you look at deaths per capita across the country, you can see that there's some parts of the country where rates were really very, very low, as I've already shown you, you know, well less than 100 per 100,000 individuals, and there's places which were much higher. Manitoba had a big second wave. Quebec, as many of you know, had a very big first wave and had a very big third wave. So there's a lot going on here, and we can dig deeper to see how everything played out. Now, this is, anytime you see data that's in French, this will be data from the public health group here in Quebec, ANES. So this is Quebec data, the data that the province is publishing on a regular basis. It's updated. It's actually very comprehensive, and lots of detail, lots of interesting stuff. Now, if you look at the cumulative mortality over the course of this pandemic going up until about March, you can see that, again, we're anywhere, according to their numbers, they don't always match up perfectly, but according to them, PEI at the bottom again, Quebec at the top. They also break things down across a number of Western European countries to give us a sense of how we're doing there. And again, Canada really looks pretty good on the mortality side of the story. Quebec, as an independent nation, plays out its numbers separately, and they're up here in between Switzerland, Sweden, and France. One of the things you can see here is people think that a lot of our mortality happened at the front end, and it's true. Some of it did, but it kept going. It kept going right up until that big third wave, the big third wave that occurred over Christmas this past year with what we thought was a relatively benign variant, the Omicron variant. Now, again, I want to point out that across all the provinces, fully vaccinated individuals as of just last month look terrific. I mean, we're talking about overall approximately 90%, and most of the ones who only got a single dose are very small. So really, we're talking about 80% got either fully vaccinated or already had a booster by the time April rolled around. So we did great on the vaccination side. However, when you look back to that first wave and you look at the percent of deaths that occurred in different groups, one of the groups that sticks out are long-term care deaths as a percentage of all COVID deaths. And here, Canada actually was at the top of the heap. 81, as of the first wave, 81% of all deaths from COVID-19 occurred in long-term care facilities. You can see that's substantially higher than most of the countries that overall our mortality rates were better. You know, for instance, Spain, UK, the US. So there's a red flag that goes up about our long-term care facilities, and this is worth exploring a little bit further. This looks at COVID-19 mortality beyond just the first wave, sort of takes us through the first 3 waves. And while we were well ahead of the curve, if you will, on that first wave, we didn't look so terrific on the second wave either in terms of long-term care deaths compared to other countries. And even the third wave, our numbers were substantial. So consistently, we kept having trouble in our long-term care facilities. And it doesn't seem like we ever really managed to get on top of that problem. Whatever the lessons were to be learned, it doesn't appear that we were doing a great job at learning them. Yes, things were getting better, but they weren't getting dramatically better, and the rest of the world was still looking a lot better than us. Now, you may ask, but why does Quebec look a little bit worse than the rest of the places? And part of the issue is probably that we have more seniors in long-term care. About 10% of the Quebec population, about 10% of the older population, I don't call seniors anyone over 65, I'm 68, so let's just call them older people. About 10% in Quebec are in long-term care facilities, whereas across the country, you're sort of looking at an average of about 7%. So we're about a third to 50% more people in long-term care facilities, which might be why our numbers look worse. However, let's be clear that we knew for many, many years we had a serious problem in long-term care. And this is a really interesting story that was published during the first year of the pandemic. And unfortunately, it describes one of our colleagues. Susan, by the way, gave me her permission to use this. She's the one that brought it to my attention initially. And this was a story about how her mother was at the Heron nursing home and passed away 6 months before the pandemic started. And at that time, Susan, who many of you know is no slouch when it comes to getting to the bottom of something, determined that there was gross negligence in the way her mother was cared for. She returned from a 5-day trip to find her mother semi-comatose, dehydrated, wearing street clothes and a nightgown over her top and near death. And she felt that nobody had been in to check her for several days. And she got her mother transferred to the hospital where she subsequently died. But Susan brought this to the attention of the nurses at Heron, who persuaded her not to call an ambulance. They did, I believe they ended up firing the nurse that was supposed to be in charge of her mother's care, but Susan was not happy about this, as you can imagine. I can vouch for the fact that I had a grandmother who was at Heron before it became Heron. And back in those days, 25 years ago, it was a pretty good nursing facility. It wasn't owned by the current company that owns it. And as many of you may have heard from the coroner's reports and the ombudsman's reports, the people who actually owned the Heron nursing home were people who had been previously convicted of money laundering and fraud and had served 1.5 years in jail. So it brings up interesting questions about how the background checks failed to identify this was not a group of people or an organization that was qualified to be looking after really sick people. I want to also bring your attention to a really fantastic book. As I started to do my research in this area, I came across a book by Andre Picard. Now, many of you probably know of Andre's writing because he's one of the more thoughtful health journalists in the country. And he has a regular column in the Globe and Mail. And if you go back through his columns, back to 2015, I think I quit at 2015, you find that he identified these problems with nursing homes long before the pandemic. He was on top of this. I spoke to him last week to ask him how did he figure it out. And he pointed out that he was taking care of 2 elderly parents in Ontario, and he was just gobsmacked with how bad things were. And once he saw what was happening during the pandemic, he decided it was time to write a book. And it's a really easy read. It's very well written, lots of citations, many of which pointed me in the right direction to know where I wanted to go with finding the right data. This is an article that he published back in November of 2020, where he asked, why were we seeing a sequel nearly a full year after the first big wave came through? He pointed out that in March and August, COVID-19 killed at least 7,000 Canadians in long-term care facilities, exposing the weaknesses in the system. And the authorities at that time swore they were going to fix this. And virtually every province introduced a one facility rule. Bonnie Henry in British Columbia, for those who you don't recall, was the first to do it, actually. She did it within the first month of the pandemic. The minute they had an individual in a nursing home who developed COVID-19, she closed down the nursing homes as far as labor was concerned, where she said to everybody, no more running around between nursing homes. I don't care if you don't have full-time hours in a nursing home. We will give you a full-time salary and you'll stay put in that nursing home for the duration of this pandemic. And of course, it makes great sense. As you know, for those of you who work in the hospital, if we have a pandemic on one floor, an outbreak on one floor, we certainly don't allow anybody to move over to another floor, let alone start working at another hospital. But at any rate, this is really important because 30 to 40% of workers across the country were juggling part-time gigs in various facilities. And this was in part because employers weren't hiring full-time. It was a great way to reduce costs. And it wasn't uncommon to see individuals, certainly here in the Montreal area, who were working in as many as 3 or 4 facilities at a given point in time. Now, as of this date, all the provinces except for Quebec have banned work in multiple nursing homes during the pandemic. Quebec still feels that restrictions would exacerbate already grave staff shortages. So Quebec doesn't have this limitation, or at least, I'm sorry, it didn't have this limitation back in 2020 in November. I can't swear to you that that hasn't changed. But earlier in the week, I was speaking to some senior long-term care facility administrators to get a sense of how they're managing this. And nobody mentioned to me that they had stopped allowing people to travel in between homes. Now, the traveling between homes story is an interesting one, and it probably is reasonably correct. This is looking at British Columbia mortality data versus Quebec mortality data by the source of where they were living at the time. And as you can see, the Quebec numbers for the community don't look very different from the numbers for British Columbia. But old Bonnie Henry there, when she clamped down on the nursing homes, they had a little bit of a peak at the beginning, and she brought this under control. On the other side of the coin, Quebec has just been had major trouble, and this was only taking us up to August 2020. There's no question we had another big surge as of this past Christmas. If you look across 3 waves, which was the only long-term data I was able to get, you can see that as a general rule, Manitoba is the exception. As a general rule, when you look at the wave of cases per 100,000, wave of cases per 100,000 population, or the deaths per 100,000 population in long-term care homes, you can see that things tend to be about the same time and time again. Quebec, as you know, had a big first wave. Their second wave was certainly better than Manitoba's and Saskatchewan's, and on a par with Ontario. And by the third wave, they were all once again right up there with New Brunswick. So if you go across here and you look at the number of cases over the first 3 waves, you can see that Quebec is a good 50% higher per capita than the rest of the provinces, but it's the deaths that are really kind of shocking. And here you can see how we did terrible in terms of deaths per 100,000 in the first wave. Sorry, I meant to be here. And the second wave, we did much better, but again, we led the way by the third wave. So that if you add all of this up, again, you're looking at close to 2-fold increase in mortality among long-term care residents compared to the rest of the country. So, if you think about it in those terms, let's assume that Ontario and Quebec are sort of, we're central Canada, we're similar, we're the closest in size to one another. You'd sort of say to yourself, well, does that mean half of the mortality in our long-term care homes in Quebec was avoidable? Now, I don't for a minute believe all the long-term care deaths in Ontario were necessary as well. But if we give them the benefit of the doubt and say there's nothing they could have done, well, it raises the question, did we have twice as many pass away because things were that much worse here? And you get a little bit more insight here when you look at these data, which are fairly recent. And we're looking here at resident deaths as across the country. And this is staff deaths as well. And again, one of the important things we see here is that Quebec at 8,170 deaths in the country in nursing home residents basically accounted for about 50% of all the mortality that occurred up until April of this year. We were also responsible for about a third of the mortality among healthcare workers who were working in long-term residence. And that became a problem too, because it turned out the healthcare workers were really getting scared by this. Now, you might ask the question, and some of our political leaders have suggested, well, you know, we account for mortality different from other provinces, so this is really just a counting exercise. Now, I didn't have the time or the wherewithal to find all the definitions of a COVID death in every province in the country. But I did look at the ones that are published in Quebec. And I got to say to you, I can't see that there's much here that would undermine the specificity of a diagnosis of a COVID death. To have a confirmed case, you have to have a positive test, and we know the specificity of tests are pretty good, and you have to have died of multiple manifestations compatible with the positive test, and that includes things like fever, coughs, respiratory difficulty, anosmia or dysgeusia, signs of radiologic infiltrates, symptoms of respiratory distress, or some sort of pathological finding. I can't see, you know, this to me is not somebody who came in for a hip replacement and passed away from a pulmonary embolus and who just happened to be COVID positive. This to me looks like COVID. It's possible other regions of the country or other countries are undercounting, but I don't see any evidence here that Quebec is overcounting. So why do numbers in Canada look so bad for our long-term care facilities? Well, there's a couple of things that come up. First of all, there's relatively low numbers of workers in long-term care per 100 elderly compared to other countries. And you can see this is long-term care workers per people age 65 and over per 100 people. You know, you got Sweden, Norway, all the Scandinavian countries up here. Israel comes in next, Western Europe. Canada's down over here with France, which is no great, you know, to be quite frank with you, I remember when all those people died, all those elderly people died in Paris during that huge heat wave they had a couple of decades ago. Lucien Abenheim was the minister of health at the time, and he had to lose his job because of all the people that died. But the fact of the matter is, it happened in the summer, and all their family members had left them in their apartments and gone off to the beach for the French national, you know, the French month of holiday. So comparing ourselves to France is hardly something to be proud of. And then you got a bunch of Eastern European countries here: Slovenia, Hungary, Slovak Republic, Latvia, Lithuania, et cetera, et cetera. So the amount we spend on our long-term workers and the numbers we have taking care of our long-term workers seems to be one of the problems. We're relatively cheap, if you will. Here shows this shows you, this is from Stats Canada. This is fairly recent, goes right up to the fourth quarter of 2021. And it shows you shortages of nurses, aides, orderlies, and patient services. And I just compared us to three bigger provinces: Ontario, Alberta, and British Columbia, because I thought it would be the best comparison that I could squeeze into the slide. And you can see that over the course of the pandemic, this is, by the way, not long-term care. This is all nurses, aides, orderlies, and patient service associates. Patient service associates basically represents the orderlies and the caregivers who don't have a professional title other than nurses, aides, and orderlies. You can see that we were running about 4,000 to 7,000 people short quarter by quarter across the system. Our numbers are not an order of magnitude different from Ontario. They're clearly a lot worse than Alberta or British Columbia. But then again, if you divide by our population, 8.5 million for Quebec, 14.8 for Ontario, and about 4.5 Alberta and British Columbia, you can see that we had the highest vacancy rate, nearly 70 versus 60 versus 22 versus 35. So one of the things it's telling us is, you know, the non-professional healthcare workers in our province are at a real premium. We have bigger shortages than other parts of Canada. And I believe that's one of the areas that we're running into trouble. Now, this looks at how much we are paying people. The hourly wages we were offering these people across, again, all facilities, long-term care, rehab, hospitals, et cetera, And you can see in the first quarter of 2020, we were lowball here, going in at $17 an hour. Around that time, $17 an hour wasn't a whole lot different from working at McDonald's, other than you didn't get the benefits at McDonald's or the paid vacation. But you can imagine how much harder the work was taking care of people in a hospital or in a long-term care facility. We recognized that we were in trouble money-wise, and we boosted their salaries by 10, 20% by the fourth quarter of 2020, and they kept rising. And as you may recall, Premier Legault and the Minister of Health mentioned they were going to arrive at a new agreement and significantly increase the wages of people working in long-term care facilities. It's interesting that by 2 months into the pandemic, even the federal government recognized we were in serious trouble with what we were paying people. So in April of 2020, Prime Minister Trudeau promised that the federal government would provide financial assistance to essential workers who earn less than $2,500 a month. Now, think about that for a moment. We're talking about providing financial assistance to people who earn under $30,000 a year. If you're living in a metropolitan area like Toronto or Vancouver or Montreal or Calgary, that's unbelievable. That's ridiculous. Nobody can earn a reasonable living, particularly when they're working that hard and they're taking home less than $30,000 a year. And you might ask yourself, well, how is that possible in a country like Canada? We have strikes all the time. I mean, if you've noticed in the last few days, the cannabis retailers are striking because they want to get the same income that the people working in the SAQs are getting in the liquor commissions. So strikes are de rigueur in our country. What happened in long-term care? And this is perhaps in some ways the most worrisome part of the whole presentation. And that's the proportion of immigrants among nurses, aides, orderlies, and patient service associates in all occupations across provinces and census metropolitan areas in 2016, before the pandemic got started, a few years before. And you can see across the provinces, you're looking at approximately anyway, bottom line is there's not much happening out on the East Coast, but Quebec, the Prairies and British Columbia, you're looking at anywhere from a quarter to 50% of the people who are doing this work are immigrants. And in fact, if you look in the cities, the numbers are much, much higher. And in fact, if you dig down into this data even further, you find that the majority of immigrants are in these populations in the city are immigrant women. And in fact, there's other studies that I just didn't have the time to show you that show that these are racialized immigrant women. I don't know what the exact numbers are, but I'll give you a statistic from, let's call it a convenience sample. One of my sons married a young woman from Haiti who came to Haiti about 10 years ago. And her mother, who came from Haiti with her, has worked as a nurse's aide in a chronic care facility in the north part of Montreal now for a decade since she came in. So I asked her the question. I said, when you're working in that long-term care facility, what proportion of the workers are immigrants? And she said during the day shift on her floor, 5 out of 6 people are immigrants. And on the night shift, everybody's an immigrant. You never see somebody who was born in Canada working a night shift in the nursing home. Now, okay, that's not exactly the most robust of data. But again, speaking to my friends who were working in the CIUSs in the Montreal area, they didn't argue with the idea that at least 3/4 to 80% of the people working in long-term care facilities in Montreal area were immigrant. And most of them, in fact, if you look at some other studies, are racialized, middle-aged women. Many of them have advanced degrees. They were nurses, they had training before they came to Canada, and this is where they ended up. So that really underscores, I believe, how we've mistreated the workforce so badly. These were people who frankly didn't have much of a voice in our system. And, it's interesting that Premier Legault mentioned in April of 2020 that he understood that there had been a problem for a long time. In fact, he took full responsibilities for the lack of orderlies in struggling long-term care homes. He said he didn't want to get into a fight with the healthcare unions when he first took office, and therefore he decided on holding off on paying public sector orderlies more until contract negotiations began. He was worried if he gave more money to the long-term care facilities where they knew there were huge shortages, that everybody that was involved in healthcare would come running after him. He said at the time that the province was lacking about 1,800 people to work in those residents, but I'll be honest with you, from everything I've read, it seems to me the numbers were much higher. He said, we came into this crisis poorly equipped, as the story about Susan Bartlett's mother will testify to. And the situation deteriorated when the virus came in, and I take full responsibility. And for many of you, if you've had a chance to read the coroner's report that came out last week, it really underscores what a horror story this was in a number of nursing homes, not just the Heron facility. Now, I sort of wondered to myself, what was the possibility that the language laws were playing a role here? And again, my friends in the CIUS pointed out that only the nurses and nurses' aides are required to pass a language test from the Quebec Office de Langue Française because they're professionals. And all the other individuals can, in fact, theoretically work in a nursing home without adequate French, but there's an understanding in the nursing homes that they will not hire someone who doesn't speak French at least moderately well enough so that if someone comes in and tests their French, they look like they're French capable. And the only other indication, the only other indication I have that language might have played a role is, many of you may not have noticed this, but as early as April 2020, the Office of Langue Française suspended the language tests for healthcare professionals, including doctors and nurses. So you no longer had to pass your language test in order to get in there and help. And this was, this was an important admission by the government that we need all the help we can get, and French or English, we don't care. We just need somebody to help out. And as Legault said, COVID-19 in Quebec, we need you. He said of the 9,500 workers absent from the healthcare network. Now, the good news is things are looking better. Quebec orderlies will be getting their $26 an hour after all. And this was announced nearly a full year ago. It's interesting to notice that these long-term workers who are finally getting their $26 an hour, fortunately, don't fall under Bill 21 because they wouldn't be allowed to wear their hijabs in the long-term care facilities where they work. And as you might have recognized, the government's in no position to restrict anybody from working in healthcare on the basis of wearing a religious symbol. Bringing them up to $26 an hour, again, it doesn't guarantee they have full-time work in one facility, brought them up from basically being at the very lowest ranking down here to this ranking approximately here. So the good news is, yes, they've moved up several ranks. The bad news is they're still very poorly paid workers compared to everybody else in the public sector. Just to give you an idea of how bad, the government reached a similar deal with workers at the SAQ more than 2 years earlier, where the cashiers and sales clerks negotiated a very similar contract and are getting approximately the same money now as the workers in long-term care. So how can we improve this situation? What can we do at McGill and at the MUHC? Well, the simplest solution, I don't mean to make light of this or fun of this, but we could put the elderly in prison where they would get a shower every day, video surveillance in case of problems, 3 meals a day, access to a library, computer, TV, gym, doctors on site, and free medication if needed, and put the criminals in the nursing home where they'll get cold meals, lights off at 7, 2 showers a week, live in a much smaller room, and have to pay rent at $4,000 a month. And I think it's sad, but it's true. We treat our prisoners better than the elderly. This is frightening. It's very frightening for somebody who's 68 years of age, and this isn't far off. Clearly, one of the things we could do is improve inspections, improve accountability in our nursing homes, make sure that they're meeting some standard. And this was an important article that came out in Radio-Canada 2 years ago now, where they noticed that among the 1,750 residences for the elderly in Quebec, there were only 4 inspectors in Montreal and 3 in Quebec, which explains why they only get visited once every 3 years, typically between the hours of 9 and 5. Nobody goes in there at nighttime when all hell is breaking loose. So they go in during the daytime and they only do it once every 3 years. And I've got papers that show the list of what proportion of nursing homes are meeting the criteria that these inspectors are demanding. And, you know, it's like 30 to 50% meet a specific requirement and the rest didn't even come in close. So they've got these metrics, but people don't meet them. On the other side of the coin, there's 18 inspectors for the animals, agriculture, and food and stuff. And the animal inspectors, they basically manage somewhere between, let's say 800 to 215 visits. I'm sorry, this is the visits to the nursing home residents. They're averaging about 500 visits per year compared to the 5,000 inspections that are being done for animal welfare. So again, it gives you a sense of how we really need a redeployment of our manpower in the public sector. Well, what can we do to improve support services for the elderly? Clearly, we need to do something about immigration. Quebec here is number 3 behind Ontario and British Columbia. But as I've already mentioned, we have twice the population of British Columbia. We got to ratchet up the immigrants as much as we can, unless we find a way to convince Quebecers that this is the sort of work that they should be doing. And it's true, in the outlying areas where immigrants don't typically go, nursing homes aren't being run by local individuals who are probably Canadian born and bred or Quebec born and bred, but the immigrants aren't going out to these places. It's the cities. The retention rate is a problem too. Not only are we having trouble bringing in immigrants, but our retention rate in a place like Montreal, 66% retention rate over a few years means, you know, we're losing a third of them. And I don't see anything in the legislation that's been occurring lately that's going to improve either the number of immigrants we get or the likelihood they stay with us. So let me finish off with a couple of slides. I've already told you, you don't have to place your bets on the resident inspectors or the inspectors for the animals. We already know there's 7 of these and 18 of these. And they do 500 inspections a year versus 5,000 here. If you go to the Office de l'Homme Français, my best guess is they have 100 inspectors and I know they do 5,000 inspections based on their annual report for complaints and various things. My estimates are based on the fact that they recently hired 50 new employees with $5 million that the government gave them, meaning, you know, also that they were getting paid approximately $100,000 a year. And of those 50 new employees, 17 were inspectors. So let's guess maybe a third of employees are inspectors. And if they've got 317 employees, maybe 100 of them or a little bit over are inspectors. This gives us some interesting ideas about what we might do. First off, we're really short on inspectors and we've got to make the system accountable. On the other side of the coin, the Office de l'Homme Français has a huge number of inspectors and these are highly trained people. They could, let's say we wanted to do an inspection once a year, which I think should be the bare minimum. Look, all my research grants get inspected once a year from our REB, even the ones that I'm just using data analysis of existing data sets. If they need to be inspected once a year, it seems to me the nursing homes need to as well. So let's say we need to triple the number here, bring it up to somewhere between 21 and 28. Well, surely we could go and get 20 inspectors from the Office de la Langue Française, even if they lose and their complaints drop down to 4,000. Nobody's going to die because of this. The other place we might want to look in terms of workers, in terms of quality of care, is the SAQs. Think about it. I don't know about you, but the SAQ is one of the best service centers that I know in Quebec. Whenever I go to my local SAQ, they're helpful, they're congenial, they know the right wine to pick in the right price point for me. I never take home a bad bottle of wine that they recommend. And in fact, they've been going digital more and more. So I don't even go in during the pandemic. I just order online. I get coupons, discounts, and the stuff gets delivered to my door. Well, now that they're doing more and more online selling, in fact, it went up 23% last year because of the pandemic and because of their online capabilities. Surely they could, if let's say not give up employees, but what if their employees were to rotate through our long-term care facilities, 3-4 months, and bring some of their client service skills to the table? These people do a really good job. They could teach the people in the residences how to perform at a level that looks similar to what's happening in our SAQs. Now you'd think, well, that's it. Grover figured out the solution. Not so simple. This is a C.D. Howe report that just came out a couple of months ago, where they project by 2041, the demands for long-term care from an aging population are going to quadruple to what they are now. So a 4-fold increase. If you don't think what we're doing right now is adequate, imagine what it's going to be like when it increases 4-fold. And they point out there's absolutely no way to do this. There's no money. We better be talking about innovation because this simply isn't going to happen. So what can we do? What can we do in our 2 institutions, in the Faculty of Medicine, for instance? At the moment, we have no policy and no program specifically aimed at long-term care or caring for the elderly. Now, as many of you know, or may know, a month or 2 ago, after a 2-year task force, we came up with a policy for making sure that French proficiency is required of all McGill medical students before they get admitted into medicine. Not that they'll improve their French with tests, but in fact, they have to take a test to get in if they're coming from outside the province. If they've graduated from CEGEP, no test is required. If we can have a task force work for 2 years on French proficiency in our medical school, it seems to me it's time for a task force on health promotion among the elderly. Not only should we be sensitizing our students to these issues, but we should be leading the way in clinical care and research. What can we do at the MUHC? Well, for those of us who are involved in patient care, I think we can be improving the clinical care for individuals who are at risk of losing their autonomy or have lost their autonomy. If they come into our hospital and get admitted, at the moment on the wards, we're looking at 30 to 45% in the CTUs at the MGH, who are basically individuals who have issues about where they're going to go when they leave. We can increase the breadth and depth of our hospital rehabilitation services while they're awaiting discharge. A couple of minutes with physiotherapy or occupational therapy is simply not sufficient. We can increase public awareness about the need to improve the care of the elderly in both the community and our institutions. When public awareness is concerned, as academics and as health professionals, we actually have a fair amount of clout. This is the message we should be getting out. We can increase the proportion of research that as a group we're doing at the MUHC RI. I know of a few really good studies. I know of some people doing really good work at the MUHC RI about healthy aging, preventing the need for hospitalization, recovering from strokes, et cetera, et cetera, et cetera. But I'll bet you there's a lot of, we've got a big skill set there, and I bet you there's a lot of opportunity for it to do more. And with a little luck, the government's going to figure this out and start putting some money into this area as well in terms of grant support. We need to support additional funding for evidence-based programs to prevent the need for long-term care. In other words, we want to delay getting into a nursing home as long as possible. And once the data starts being compiled by groups like ours, we need to make sure, we need to get out there. It's not just publishing. We need to get out there and make sure decision makers are doing something about this. And we need to hold our healthcare decision makers and political leaders accountable for the quality of the services we're providing to those who require long-term care or who are trying to keep out of long-term care. Now, it's not complicated. I actually found a study. I've only found one, unfortunately, but someone actually looked at what were the risk factors for a nursing home admission. And over 2 decades of follow-up, diabetes more than tripled the risk of nursing home admission, smoking, inactivity, elevated blood pressure. And they concluded modifying lifestyle, especially middle age, may reduce the risk of admission, but it's frightening how little work has been done in that area since this paper. The one exception, and there's actually even a Cochrane review now on it, is the exercise trials to prevent people from falling. And the data is overwhelming. 81 trials, nearly 20,000 participants, showing that a modest exercise program can reduce the rate of falls by 23%. It can reduce the rate of fall-related fractures, and some types of exercise where they really start to build the program around fall prevention, like the group in New Zealand who came up with the Otago program, which you can download how we should do this. They can reduce the rate of falls by up to 34%. That's strong, clear data. I'm disappointed in our own group that over all the years we were doing stuff at CHIP and some of our online programs, we never went after doing something about stopping falls. We were teaching people to increase their muscle mass, lose weight in the Drop 5 mission, improve their heart health, their brain age, and improve their sleep, pain management. We needed a fall prevention mission. And I'm happy to say that as this morning, my group and I got so excited by this, we decided, well, we're going to start something and we'll find money eventually. All right, I'll stop there. I think there's so much room for us as a community of health professionals and researchers to do more. And if we don't do it for academic and professional reasons, we should do it for purely selfish reasons. And that's that it's only a decade away or two for many of the older people in our group. And boy, the status quo looks terrible. And if the C.D. Howe Institute's correct, it's only going to get worse. And I'll stop there.
Thanks, Stephen. That was a really excellent presentation. I mean, from the problem to the data to the potential solutions, it was really wonderful. So I'll open up the floor for any questions or comments. There's praise coming in on the chat from several people. Sasha Bernatsky says you look 58, not 68.
Thanks, Sasha.
What kind of compliment is that, Sasha? You should have said 38. I mean, that was
I'm
a great.
It was a typo. It was a typo. I meant 38.
You
That
look
was a
the same
great
as when you were
thought.
my attending when I was a resident, Stephen, and we won't say how long ago that was.
Yeah, you don't have to say how long ago that was.
That's to protect me, not you.
I think you beautifully highlighted not only the challenge of aging and the poor staffing of long-term care, particularly in Quebec, it seems, but the lack of prioritization. And as we all know, other issues have recently been prioritized over these really pressing problems, and that has to be addressed. There's no question. So
I think you're right, Kabera. You know, one of the examples I used in it, it's a painful example, but if you look at the media attention that horrible shooting in Texas got last week, with 19 kids, and I'm not trying to suggest it's not anything but horrible. we're talking probably about thousands of older people in our institutions who died unnecessarily at that moment. Would they have lasted, 10 years, 5 years, or 1 year? I have no idea. But the point is their death was unnecessary. Nobody should die because of dehydration, or because they haven't been changed for days, or because they haven't been fed, or because they're left sitting in a chair. And it amazes me when you start to look at the numbers, how we, the public just, this is not major news for the most part.
I think Kevin has a question there.
Well, it's just a comment, Stephen. I think we all know this. We live in a society where we'd like to pretend that aging doesn't exist, right? I mean, there's a multi-gazillion-dollar industry with, anti-aging, this and that, and so on. And, we're and the corollary to that is that the elderly are somehow less worthy, or we'd like to pretend that they're not there, right? I mean, although of course, as you said, it's soon enough it's we, but I mean, this is part of this is very much a part of an undercurrent of the culture we live in, and it's also why I think this is one of the reasons that this, Quebec's dirty little secret had been allowed to fester for so long. And again, I know it's not the only jurisdiction, but I think it's emblematic of many of the challenges that you have raised, Stephen.
I think you're absolutely right, Kevin. And I'm not trying to suggest that I believe Quebec is only at fault here. I think there's plenty of other provinces who could have done a much better job, Ontario included. But when you look at what BC did, I think their results were impressive. At least they acted on saying, we're going to put this money down and you're not moving between nursing homes. And they did that the moment there was one infection in a nursing home. That's political action.
I just have a comment, really wonderful talk. And I think it might, your data where you looked at deaths from COVID by wave in the elderly, and showed that Quebec was consistently leading the pack. It's probably even worse if you consider, there's a lot of literature on excess deaths year after year. And really, if you wipe out the frailest frail, there should be a paradox. These are not independent events year after year, because then the remaining people are in some ways a healthier bunch, or a less frail bunch. And yet to still be leading the pack after having wiped out so many people means it's really something in the operations, I think. I calculated this early on for a COVID-related talk, and over 90 years old, the first wave, I think, wiped out something like 5% of the Quebec population over 90. It was really devastating.
I think you're right, Benjamin. But I also think part of what it's showing us is the tremendous health impact that 2 years of social isolation had on elderly who otherwise would have gone the distance. But there's nothing like putting them in an apartment. They're not allowed to socialize. They're not allowed to exercise anymore. Families afraid to come and visit them. And before you know it, they work their way up the curve. I personally think that's what's happened.
All right, so there's a lot of praise coming in on the chat, including from Susan Bartlett. Alicia has a question. Could inspections be, Alicia, you're welcome to unmute. Otherwise, could inspections be hired to consulting firms that look at other quality related topics, such as tourism, hotels, restaurants? Their team could be trained specifically for this.
Of course they could. I don't see any reason they couldn't. Ben, I see that.
Yeah, Suzanne has a question. I'm sorry, I didn't see that, Susan. Go ahead.
That's okay, thank you. So I think, the idea here is that there are many cultures, people, don't go to long-term care, they stay home. And part of the, the trust is to try to get people to stay at home longer, as you've mentioned. And the cost of doing this is high as well, but likely more affordable than the multiple long-term care homes, in fact, that the government is about to build. And the question is, how do we keep people at home in a way that is actually efficient and safe? And decreasing falls in the elderly is extremely difficult, not only because of the fact that they become sarcopenic and you can have interventions that prevent that and improve that, but you also have to improve about the environment and the kind of the built environment, the architecture outside and within where people live, to make it so that if they fall, their risk for actually injury is much less, and so on. So it's a kind of a total revamping of the culture and society in a way, and the built environment. And I think it's a shift that needs to happen, not only when you start looking at the elderly, but when you start looking actually at middle-aged people before they go on to becoming so frail that in fact there's very little we can do.
I think you're absolutely right about that, Suzanne. I think I think waiting until someone is 70 or 80 to jump in at this is probably a mistake. I'm not saying it wouldn't do some good. I believe it probably would. But if it's anything like the dementia story or the diabetes prevention story or the cardiovascular disease prevention story, you got to get in there at least a few years before symptoms or events start occurring. Once someone starts falling, we've missed the opportunity, to make huge differences.
Sasha, you have a question or your hand raised?
So maybe just a call to action to end the hour with. So what Stephen said made me think about how McGill is, and MUHC and the Research Institute, we're all about excellence. And these nursing care homes, the long-term care homes, they're not really hooked into that. And I was thinking if they don't have young minds doing research, exciting people about providing quality care. So it would be interesting if we could partner up and start really engaging in research projects with those institutions.
I bet you I think you're absolutely right, Sasha. I bet you it's not going to be that hard to find at least a dozen places that would be delighted if you come in there, and particularly if you're not just doing research, but if you're also trying to improve the level of the wellness and health promotion programs that are being offered them, or testing. We've got people in our group that are testing new devices, coming up with new approaches to stroke rehabilitation, walking, preventing osteoporosis. The list goes on and on. I think they'll be interested. Well, we need to find some funding, but frankly, I also believe we can get some money from the foundation too. There's a lot of that foundation money is very interested in, okay, what are you going to do to make my life better one day?
Okay, I'm not sure if Stephen's cut out or.
No, I'm here.
Okay, good. Yeah, I think, that's a really great way to end it, in fact, thinking about our research roles. Also, there's, I think, some deep researchers in deep prescribing who have actually plugged in with long-term care facilities within Quebec and abroad. And so we should look to that as a big undertaking led out of the RI core. So thanks again, Stephen, for this really awesome talk. Oh, sorry, Nandini, one last question. It's a really hot topic, Stephen. You want to comment, Nandini? You might be
still there?
You're on mute, or maybe she's disconnected somehow. Okay, well, I'm sure she can reach out to you. So thanks again, Stephen.
I should mention, for those of you who don't know, Nandini's in the wellness business as well, in terms of trying to run a gym and stuff. You want to have a laboratory where you can try some of these things out. There's so many opportunities within our group. We just need to be talking to each other.
Agreed. Okay, thanks so much, everyone, for joining. Enjoy the rest of your day.
Thanks very much.